Alright, welcome to pulmonary disease. So I'll talk to you guys a little bit through this one. Please remember to fill out your disease chart. This next exam is going to have a lot of neonatal pulmonary disease on it. So let's go through it. So RDS is the first biggest one that we'll talk about. And these are old statistics, and I won't test you on the statistics, but it's inversely related to gestational age, which means the younger the kid or the younger the gestation that they're born at, the more likely they are to have RDS. And that's the big thing to remember. If it's safe to do so to keep kid inside a mom, and it's safe for mom, then we're going to try to keep that kid inside as much as possible. That reduces their risk of RDS and a lot of other things. So the younger the kid, the more likely they are to get RDS. So it's inversely related to gestational age and birth weight. So the bigger the birth weight of the kid, let's say we have a 28-weeker that's at 1,000 grams. It's big for a 28-weeker, and that's actually a good sign for that kid. So the younger they are, the higher the odds are that they'll develop RDS. It's pretty rare in kids older than 37 weeks of gestation. It still can happen with meconium aspiration, pulmonary edema, things like that. Ventilator-induced lung injury, it can still happen, but it is a lot less likely to happen from surfactant deficiency overall. In 2007, which is a long time ago now, it was pretty big, but it was also known as hyaline membrane disease, which is what was a more accurate term back in the day, because what's going on in the respiratory zone is it's literally forming hyaline membrane. It's forming scar tissue, this hyaline membrane, that thick scar tissue. And so this is the statistics your book gives. Like I said, I won't test you on these statistics, just sort of give you an idea. The younger they are, the smaller they are, the more likely they are to get RDS. And these numbers will change from year to year and from region to region too, depending on how they practice as well. Decreases for RDS, chronic or pregnancy-associated hypertension. So this is when we're looking at with maternal heroin use, where mom's on drugs, prolonged premature rupture of membranes, antenatal corticosteroid prophylaxis. These will all decrease the risk of RDS because the baby's getting more blood flow or having to mature faster because of some sort of survival, fight or flight, some sort of way to actually keep them and develop them faster. Since they're developing faster, they're more likely to develop their mature surfactant faster as well, and therefore they're more likely to have a decreased risk of RDS because they've had to mature faster in utero. So those things will decrease RDS risk, and it will be increased risk of RDS with things like maternal diabetes, multiple gestation, so your triplets, so on and so forth. C-section, of course, that's retained fetal lung fluid. A very, very fast delivery or precipitous delivery, that's where they're more exposed to issues with infection and things like that. Fetal asphyxia, of course, if they don't get the oxygen, their lungs won't have what they need. Cold stress, maternal history of affected infants, if mom has a history of infections with previous kids as well. It's more common, or it's highest, in preterm male Caucasian infants. So the nurses like to refer to this as wimpy white boy syndrome. So if you hear it out there, that's what they're talking about. So if you have a Caucasian male that's born prematurely, that's very increased risk of RDS association. RDS as a result of insufficient amount of surfactant is most common in the NICU population. So this not only means their respiratory zone's underdeveloped, but also the vascular part of the respiratory zone, those capillary networks, are also under development as well. So 28 to 38 weeks of surfactant is secreted into the alveoli. So if you get a kid be 28 weeks and less, then they won't have much surfactant or much mature surfactant in their respiratory zone. So that's why some of these kids, if we're at 20 weeks or less, we might actually take surfactant to the delivery with us. So if they're born before 28 weeks, They're underdeveloped in their respiratory zone as well as in their terminal air spaces. So that's in your transitional airway. So if you remember way back in pulmonary, it's those transitional airways that actually will have the highest amount of flex because there's no cartilage there, but also they're not they are not as structured with vascularity as the respiratory zone is. So the path of least resistance when a ventilator breath goes into them is going to be descending the transition zone and not actually the respiratory zone because there's less vascularity there. The compliance is the highest in their transitional airways, which is what can lead to PIE and other things. So this is what makes it pretty important for us to use very low bending pressures, very low venting tidal volumes, very high frequency ventilation as well is a big help here to avoid destruction of that transitional airway. So extremely compliant chest wall of the preterm infant. This can lead to atelectasis because, like you and I, our rib cage is formed, and so when we exhale, that rib cage sort of keeps that FRC, it keeps that suction of the lungs open at end exhale. But these little guys, since their chest walls are pretty much just gelatin, so to speak, they're more likely to collapse back in further than you and I, and so they're more likely to have atelectasis. And so when this atelectasis happens, it decreases compliance, increases air resistance, and will increase their shunt-like effect or increase their VQ mismatch. So this is a shunt-like effect. So that's where you'd be like, give them oxygen, but not a good idea, especially the preterm, to give them more FiO2. That's usually a very, very bad thing. When this happens, they'll have hypoxia, of course, hypercapnia, high CO2s, respiratory acidosis, of course. The pulmonary arteries will reduce blood flow with this respiratory acidosis, which means there's less blood going through the respiratory zone, which means there's less blood picking up oxygen to be circulated through the rest of the body, therefore hypoxia and hypercarbia. This means the alveoli is not getting the nutrition it needs because remember, your tracheobronchial tree gets nutrition from the vessels that come off the aorta, but the respiratory zone itself gets nutrition and blood flow to the tissue of the alveoli itself from the blood flow going through the lungs. So if a kid has pulmonary hypertension or decreased blood flow going through or to the lungs, that means the alveoli are going to then be underdeveloped and undernumerated because remember, the fifth stage of fetal lung development is alveolarization, and that takes place up to around 18 months and can last up to 8 years of age. So this means the alveoli are going to become damaged if this kid has pulmonary hypertension. So big issue here because it can increase the right to left shunt because you have higher pressure in your pulmonary artery than you do in your aorta at this point because of the pulmonary hypertension. So it will force deoxygenated blood into the aorta. So it forces a right to left shunt when a kid develops pulmonary hypertension. So normally a left to right shunt with the PDA, but in this case with pulmonary hypertension, if it's severe enough, it can actually shift it to a right to left shunt. So it can actually, instead of being acyanotic, it can shift it to being cyanotic. So PDA is going to be your big one. This can also happen with the foramen ovale. If the right-sided heart pressures are higher in the atria than they are in the left atria, then that will actually force the foramen ovale open and then cause a right to left shunt. And that's what I've seen in adults is they go into severe pulmonary hypertension. This is adults go into severe pulmonary hypertension and their PFO, patent foramen ovale, opens or it pushes that open, and then now they have a right to left shunt that's pretty significant, and that's why I was down there doing the shunt equation on those big adult people, is to see how bad the shunt was it worth closing? If we did close it, would there be too much pressure then on the right side of the heart? Because now it doesn't have that pop off. You can also have this increased right to left shunting within the lung itself. So the pressure is so high that it just passes through the AC membrane without spending time and dwelling to pick up oxygen and get rid of CO2. So that will be a right to left shunt. So RDS causes a shunt, especially if they already have one going on, which most of these preemies will. So this will mean their hypoxemia will get worse, and because they're not getting as much oxygen to their muscles, they'll go into a metabolic, or tissues or organs, they'll go into metabolic acidosis, which will increase pulmonary vascular resistance or pulmonary hypertension even more. So it's a vicious cycle. So we got to do something to reduce that right to left shunt there. So the big thing here is the more acidotic they are, the less likely they are to produce surfactant, which is what their body needs to make, which means their lung compliance is going to get worse. Their gas exchange, their CO2s, their pH, they're all going to get worse. And so fetal lung fluid is going to be very, very poor to be reabsorbed, and they'll actually start to develop pulmonary edema from all this as well. So that will even more that will have even more effect on diluting the surfactant that they do have and make their compliance even worse. Anytime you get a premature kid that has pulmonary edema, their compliance will get worse because you're diluting the effective surfactant. Signs and symptoms within the first 6 hours, usually they'll be tachypnic. That's the number one thing that you'll see. You'll see some retraction, some nasal flaring, some grunting. The respiratory rate might decrease if they're going into respiratory failure. Well, that's what you would see with like someone with severe asthma, where you start to see their respiratory rate be fast, and then if the respiratory rate's normal, and then you would see the respiratory rate be low because they're tired out, they fatigued. So in this case, it would be sort of the same thing here. That grunting, that's that expiratory grunting, just to help maintain PEEP. Sometimes stage 4 COPDers will do that as well, just to help back pressure. You'll see retractions, like I said. The abdominal wall will be moving as the chest wall pulls in. They're working that much harder to breathe. Lung sounds just be very, very diminished, and they'll be working hard to breathe. So their blood sugars, they're going to blow through their blood sugars quickly. ABGs, moderate to severe hypoxemia, of course. Hypercapnia depends, and acidosis, depending on how far into it they are. If you do see a mixed acidosis, that means it's gone pretty far. They've gone into both a respiratory CO2, and they had low oxygen delivery to their tissues, and that's why they're now in a lactic acidosis as well. CO2 may be normal or low at first, just like all those diseases we did in disease class, but as they begin to fail, they'll go into hypercarbia. Chest x-ray, ground glass, or GGOs, ground glass densities, or ground glass opacities is GGO. The heart might be a little bit bigger because it's having to push against pressure on that right side especially. The thymus, usually always present, that's pretty normal on a lot of these kids. And RDS is unlikely. If their LS ratio is 2 or more, that usually means they have had mature surfactant. So here's an x-ray of RDS as it goes through the 4 different stages. Stage 1 would be A, stage 2 would be B, stage 3 would be C, and stage 4 would be D. And you can see how that just ground glass opacity just continues to show up and show up and show up until it gets really, really bad. The ET2, I want to comment on it. If you look in B, in A, this kid's not intubated, and also in C for some reason. But in B and D, these kids are intubated. You'll see the ET tube, the radiopaque line here. Let's see if I can make a draw here. So you see the radiopaque line here, and then you'll see the outline of the left main stem and the right main stem. So that ET tube's in good position because it's above the carina and below the clavicle. So now here you're looking, here is the left in D, oh heavens. And then here's your radiopaque line here. but you want to make sure that it's below what's called the thoracic inlet, which is the level of the clavicles. And if you're at the level but not below it, then that ET tube's a little bit high. So in this x-ray, this ET tube's actually high, and this kid is at high prone for an accidental extubation here. So a lot of space in between the carina and the ET tube here, and it may only be a ½ centimeter for how small this kid is, but that's something that we just have to deal with. So very, very small tube changes. Here in C you can see the main stems pretty well, but just want to comment on that tube position there. It's a little high. Now sometimes that could be the kid's chin was tucked down, which would mean the ET tube would pull up and out posteriorly. And then in B, it could have been that the kid's head might have been in a sniffing position and pushed it down or inferior. So that's something we just have to watch out for. So when you take an x-ray, think Canada, right? Think the kid is facing straight, neutral head position every time we get an x-ray. Otherwise, that tube position throw us off. Prevention. The first line treatment of RDS is prevention. This might come in handy with an exam you guys will be seeing soon. The first line treatment is prevention. So unnecessary cesarean, in other words, we're not going to retain fetal lung fluid. We have that higher chance with an RDS with a C-section just in general. Good management of labor and delivery, high risk variability. That means we're giving mom steroids if she needs it. The kid's getting interventions early if they need it. We've been able to predict pulmonary maturity. In other words, we look at their gestation, or we get amniocentesis, or we get a gastric aspirate. We get something to look at their maturity, and we can treat them early on. So the earlier we treat them, the better. And then if the kid needs it, then we accelerate their pulmonary maturity, which means giving mom steroids. That's that shot of betamethasone, hopefully at least two different shots. They can do dexamethasone as well, but betamethasone is the preferred one. Prevention of asphyxia, that means we're going to put baby on monitor, make sure baby's being healthy in there. If baby starts having variable and or late decelerations, then that means we might expedite the delivery to avoid fetal asphyxia overall. So give mom steroids is the big thing here. It's reduced RDS by about 50%, which is huge. And then if they do get it, it's less severe than what it used to be if they did not give mom steroids. So this is giving mom steroids, maternal. It's been shown to reduce duration on the ventilator as well for these NICU babies. It's reduced their intraventricular hemorrhages. Because we don't have to use as much vent pressure, we don't have to have as much thoracic pressure, which means we don't have to have as much intracranial pressure, or intraventricular hemorrhaging is a lot less likely because we're using a lot lower vent pressures, which is awesome. Reduces the risk of necrotizing enterocolitis. That's GI. Because we're developing their lungs more, we can have more pressure in their lungs, or we can have less pressure in their lungs. We can get them started on feeding and get them extubated sooner, and get their feeding started, get their GI tract online sooner. Reduces sepsis because they're able to get nutrition because they're eating sooner because they're off the vent. And it reduced developmental delay because their nutrition's there, they're breathing better. It's a good cycle if we can. So maternal steroids, if they're looking at a labor between 24 and 36 weeks, it is indicated. Hopefully 2 doses are given. It's an IM shot in the glute. They're hopefully at least 24 hours apart. They can give them as soon as a Q shift at 12 hours apart. Beta is preferred, but they can do dexamethasone as well. So dexamethasone or Decadron was associated with lower rates of RDS and BPD, but they're still prefer beta because PVL was an issue. If they give the steroids and the kid comes at term, makes it to term, or 37 and 5, or so on, then no harm, no foul. It's not going to mess the kid up if they don't come early and mom gets steroids. Treatment and management, prevention, like I said, is the big one. This is where we look at metabolism, surfactant production. It prevents right to left shunting, so if we can get them that, that's good. Fluid management, this is a big thing, because if you give an adult too much fluids, what happens? They develop pulmonary edema, right? Non-cardiogenic pulmonary edema. Well, these kids, you give them too much fluid, they'll develop non-cardiogenic pulmonary edema, and then they'll dilute their surfactant, and then they're not going to have poor lung compliance, which means we're going to have to go up on our pressures. It's this whole very, very bad cycle. If we don't give them enough fluid, then they'll go into a metabolic acidosis, right? So we got to make sure that we have good, equal fluid management with these guys. Reduce the metabolic demands as much as possible with these kids. If they do have atelectasis, we need to prevent it, so that might be going up on our PEEP. PEEP of 5 to 6 is pretty typical on these kids. If we have to go up to a PEEP of 7, we might, but usually if we're going up on the PEEPs like that, they might switch the kid over to an oscillator. That will also, having a higher mean airway pressure will help reduce pulmonary edema as well. The idea here is to minimize oxygen lung injury as much as possible. So that's that free radicals part there. Because remember, under high FiO2s, your type 2 pneumocytes do not want to produce surfactant. Neither do your cilia want to move either. So the higher the FiO2 here, the worse and higher chance of lung injury you have, and therefore causing RDS on these kids. So that's why you'll see many kids on a vent in a NICU on room air or anything less than 30%. If a kid's on 40% in a NICU, that's usually a high FiO2 for them. The adult world, that's normal for an adult to be on 30%, maybe, but 40% in the adult ICU, we're thinking about extubating. 40% in the NICU, we're thinking about surfing, giving them more mean airway pressure or switching them to an oscillator. We're thinking about something more because that's high FiO2 for those little guys. So minimize lung injury caused by mechanical ventilation. This is, we're going to have to look at how much pressure we're using or volume we're using, or what their x-rays are looking like. If things are starting to look bad and their compliance is starting to look worse, they might consider surfactant therapy. But notice that's underlying is nutrition. Nutrition is a big thing for these patients, because if they don't have the nutrition to develop their respiratory zone, then they won't have the nutrition to develop the vascularity of the respiratory zone. Then they won't have the nutrition for the vascularity to make more surfactant, to make more alveoli, to help them get better faster. So nutrition, other than keeping the baby in mom and giving mom steroids, so other than giving mom steroids and lung protective ventilation, nutrition is the biggest thing you can think about. So the earlier we can get nutrition in these babies, the better, and less likely their lungs are to have long-term damage. So RDS, pretty big deal. That's why we started with it. BPD. This is usually kids that survive RDS usually will have BPD. These categories are based on how much oxygen therapy they're requiring, and this is a little skewed in Colorado because we are at altitude, or if you work at a place in Utah or wherever that's at altitude, that can skew the level of BPD on these kids. Some of these kids with severe RDS that have BPD from their RDS, we'll tell the parents, hey, if you move to Florida, they won't need to be on oxygen at all. And some of these people do relocate. I've known many families in my practice that have relocated to Florida itself just to help with those kids developing early on. They were able to relocate. So based on duration, chronic lung disease has been used as the diagnosis for any of these kids that are oxygen dependent at 28 days of age. BPD is more commonly used than CLD. But CLD, just like COPD, is an umbrella term for all oxygen-dependent babies. BPD is more specific to someone that's usually post-RDS. So this is the scoring for mild, moderate, and severe BPD. I may not ask you to memorize this, but you should notice what it's looking at and what's involved with it, but I will not make you memorize this. Incidence and pathologies, BPD 15 and 50% less than 1,500 grams. So it increases with the smaller they are. Sound familiar? Right? Just like with RDS, the smaller they are, the more likely they were to have it. Same thing here. The smaller they are, the more likely they are to have it. Or the more preterm they are, the more likely they are to have it. Right? Lung immaturity is going to be the big factor here. If they go into respiratory failure, let's say they get a sepsis or pneumonia or anything like that, even if they're term, then they can sort of still develop BPD. If they're oxygen dependent and they're on oxygen supplementation, of course, if they're on positive pressure ventilation, especially with villies that still go on, unfortunately. So factors of BPD, endotracheal intubation is going to be one of them. Were they on positive pressure ventilation? How many intubations did they have? Were they using higher FiO2s, right? Did they go above 30% for a prolonged period of time, 40% for a prolonged period of time? How prematurely were they? Did they have previous children that had pulmonary issues? Was there a lot of inflammation, like a pneumonia, that went on? And did they get volume overloaded? These are all factors that will go into how severe their BPD is. So if we can control these factors a little bit more, like using non-invasive, lower FiO2s, higher mean airway pressures, keeping them in mom as long as possible, reducing inflammation as much as possible, so in other words, gentle ventilation, avoiding our fluid being in excess, all those will help reduce the severity of BPD. So the big thing it's linked to is oxygen toxicity, barotrauma, too much pressure, just pounding at their tissue, just that punching of that respiratory and transitional airway. Heat inductus arteriosus, if that's open, then it's a left to right shunt as long as they don't have pulmonary hypertension. So if it's open, it's a left to right shunt, which means fluid overload, which means diluting surfactant in their lungs. So they will then be more likely to form hyaline membrane. They'll have the tissue in their alveoli, the type 1 pneumocytes, will start to cause necrosis and start to die off. They can develop almost like a pulmonary fibrosis with this, where it's that hyaline membrane, that scar tissue is forming. And they can even get bullae, just like stage 3, stage 4 emphysema patients can, that can form on their lung tissue itself. And then obviously they might develop pulmonary hypertension as well from the hypoxemia, from all this that's going on, just like you might in an ILD patient, just developing that pulmonary hypertension. So they might be oxygen dependent because they have this going on. They're not going to have a complete development of their lungs, and that's going to be one of the big things here. So intermittent positive pressure ventilation, if they use PIPs or total pressures above 35. So that's why, just like the adults, we like to keep their plateau pressures under 30. And on a kid, we like to keep their total pressure under 30 if we can. If we keep their PIP, which means it's their IPAP, their total pressure, under 35, that's one of the big goals that we can use. But usually we try to keep their total pressure under 30 if we can. Ventilation-induced lung injury or villi release a lot of cytokines that just amplify the tissue injury process. More inflammation, which means worse oxygenation, which means we're going up on our FiO2s, which means we're making less surfactant, which means we're using more pressure and more volumes on our ventilator. It's a vicious cycle. High tidal volumes also can compromise the response to surfactant therapy. In other words, we cause that scar tissue. We can give surfactant all we want. It's not going to do anything for the scar tissue and for the inflammation that you cause by doing too big of a volume or too much pressure on these kids. It's not going to reverse that damage that someone already did to these kids' lungs using your ventilator. Preterm infants have lower concentrations of antioxidant enzymes, which means they're more likely to get oxygen toxicity. That's why in adults on 40%, we're not as worried as a neonate on 40%. That's a pretty big deal, so that's why we try to keep them, if we can, as low on their FiO2 as possible. Room air is a very typical thing here. Presentation for BPD, usually they'll have hypoxemia, respiratory acidosis. Their bicarbs will be high, look a lot like a COPD. EKG will show right axis deviation, which means pulmonary issue. So every time you're looking at EKG and you see right axis deviation, you think pulmonary. Left axis, usually thinking cardiomegaly or like CHF type things going on. So with the right axis, you're thinking pulmonary or right ventricular hypertrophy, which would be secondary to pulmonary hypertension, causing that back pressure of the right heart. Respiratory rate will be high, tidal and low. That's because their compliance is low. Their raw is high because their compliance is low. Nutrition is a huge thing here. The better the nutrition, the better these kids' long-term chance of being normal down the road is. So the earlier we can start these kids on feeds, the earlier we can get them mom's milk, the earlier we can get nutrition in them, the better. And vitamins A and E are going to be the big ones because they're antioxidants. And we'll talk a lot about this, or you'll see this a lot in the NICU rotation. But big thing's going to be nutrition. Nutrition is a big area for us to work on in the adult world. In the NICU world, it's something that's already stressed, and it's shown to help these kids recover and develop better from pulmonary or prevent pulmonary injury. It's a pretty big thing. A lot of kids who have severe dysfunction can progress and might go into persistent pulmonary hypertension or right-sided heart failure. Their airway can be damaged and show bronchiomalacia. They can have a lot of issues where they might just plug off. So the big thing here, if a kid in a PICU has a history, or a kid shows up to your emergency room and has a history or diagnosis of BPD, if they get an infection, if they get RSV, it can be very life-threatening for them. And so this is why they might qualify for a drug called Synagis to help prevent RSV. And this is a shot that's given once a month during respiratory season. It's usually given for the first year or 2 years, depending on how premature the kid is. So it's called Synagis, and it's a very expensive drug, I will tell you that from personal experience. But for usually that first year to 2 years, and that can be life-saving for them. So these babies are not supposed to go out. They're not supposed to be taken to Walmart. They're not supposed to have people come and touch them and hold them and expose them to all these viruses and things like that. These babies are, for all practical purposes, hands-off babies for people that are sick, for people that are strangers. They are kept as much as they can from a pulmonary infection because it can be life-threatening and alter their future pulmonary function altogether. It's a big ordeal. And this is the clinical progression of BPD. You sort of see the upper left corner here, where this kid, I think, yeah, that's still an ET tube. Oh heavens, we'll have to comment on these. Here. Oh, I don't think I can go back. On that last x-ray, you can see the top left was sort of the beginning, top right was middle, and bottom left was sort of it progressing. The ET tube position was a little off in those x-rays, and that's something we'll have to talk about when we get back together. The cornerstone of management of BPD is prevention. Just like RDS, prevention is the big thing. Therapeutic goal is to give them support without compromising their lungs. So we'll be as gentle with their ventilation as possible. Just because we'll let them run lower saturations, we'll let them run lower PO2s, we'll let them run higher CO2s, we'll let them run on a lower pH, just like you would with someone that had severe emphysema. Same thing here, you're going to let them be a little bit more hypercarbic, acidotic, hypoxic, than you would your traditional term kid. So you're going to let them go with permissive hypercarbia here. So non-invasive intermittent positive pressure ventilation or non-invasive ventilation can be something that we do here, and this is usually through that RAM cannula. So if you Google RAM cannula, you'll see pictures, and I remember showing you guys pictures of my daughter on RAM cannula as well. Well, both of my daughters were on RAM cannula for a little while there. The big thing here is we're going to have lower oxygen saturation levels, so you should know what your saturation levels are for your goal levels are for each baby that you're taking care of. Just like someone with emphysema, we're going to be okay with lower saturation levels. Some of these babies, we might give them nitric oxide or give them an inhaled vasodilator, or put them on sildenafil, the generic name for Viagra, as well, which is what it was originally designed for. It's been shown if we give them a pulmonary vasodilator to diminish inflammation, it reduces infiltration as well as enhancing their development because it increases blood flow and more nutrition to the alveoli, therefore better development of the alveoli, therefore better development of the surfactant producing parts, the type 2 pneumocytes. It's just beneficial in so many different ways. So the big thing here is they might use nitric on some of these kids. Just understand, especially when we get to the last slide, nitric, the younger they are, the less likely it is to be as effective with current medicine that's out there, and so we'll talk about that there. Treatment, small AT tubes, so if they're between a 3.5 and a 4.0, just as a blank example, we're going to pick the 3.5. The smaller the tube, the better, because we want a little bit of air leak. And that air leak is going to help prevent back pressure in their lungs, which means, because remember, these tubes are uncuffed, and that means the less back pressure, less ventilator-induced lung injury. And also more gas, or CO2, is actually getting pushed out or flowing out, sort of like a high flow, heated high flow nasal cannula type situation. So that can help be lung protective as well. So if they're in between sizes, we're going to go with the smaller of the in between sizes. Lung protective ventilation, of course, we're going to use low pressures, keep their total pressure below 35 or 30 if we can, and or use the volume ventilation, which volume ventilation in these kids is your dual controlled mode, so your PRVC mode, whatever vent you have, as long as it has that proximal pneumotac like Hamilton's have, then you should be good. High frequency ventilation, so the jet and the oscillator, and or the oscillator would be perfect, especially for these patients, because the tidal volume is smaller than their anatomical dead space. It's ARDS net ventilation on steroids. It is high frequency and usually respiration rate between 300 and 600, and very low tidal volume. So it's as lung protective as long as it's run appropriately as you can get. CPT, we're not pounding on these kids. Usually it's using vibration. Vibration helps mobilize secretions. Because remember, with high FiO2s, cilia do not move. They're stunned. So that's why they might use vibes on these kids. Bronchodilators, this usually is Zopanex with these kids. Theophylline or caffeine. Caffeine's usually the most commonly used here. Plus, we usually have to give it for apnea prematurity anyway. So it has benefits for a bunch of different things. Heart, if they get a lot of fluid, or if they get blood, or if they get platelets, they might give them Lasix, digoxin if they're going to heart failure, but Lasix would be if they get a fluid administration or blood administration or anything like that. They might give them a Lasix dose afterwards just to prevent pulmonary edema or any issues there. They also might give them, instead of Lasix, because it can also take your potassium and your electrolytes down, they might give them aldactazide, which is a potassium sparing diuretic. It's not as strong as Lasix because Lasix is a loop diuretic. So aldactazide would be the one that you'll see there. The other advantage of aldactazide is it also reduces inflammation. Nutrition, make sure they're getting the right nutrition. Vent strategies, low tidal volumes. If you're using volume targeted ventilation, not tidal volume control, right? Not ACVC. We're talking about PRVC. We're talking about volume targeting. Short eye time, so 0.3 to 0.4. In that range, we're usually not going past 0.4 on these little guys. We might go up on their PEEP from like 5 to 6 or from 6 to 7. Usually that's as high as it will go. But you might see that change depending on where you're working. The idea here is to titrate down their FiO2 as much as possible. That's one of the biggest damages we have. They can't protect themselves from an oxidant injury like an adult can. Gas exchange, we need to target lower saturations. They might do 85 to 92 on these kids in hypercapnia, hypercarbia. Just keep them above 725. Like, they'll change that goal just like your adult patients. Complications, obviously toxicity is going to be the big one. Developing an air leak syndrome like a pneumothorax is going to be big. Brain bleeds, if we go up too high on their pulmonary pressures, that's a big issue there. Stenosis malacia, of course, from prolonged mechanical ventilation. Usually with BPDs after 2 years old, and this is sort of an older statistic here that the book quotes. It's not great on most of these kids. So I put this in here. This was in your Walsh book. This is looking at things that can cause respiratory failure for your preemies, and all the things that can cause ultimately chronic lung issues. And so this is just a way to sort of overall look at everything that we sort of just talked about: vascular injury, airway damage, intestinal damage, right? So interstitial damage, sorry. So all these things can lead to chronic lung disease, and that means these kids may not get on, they might have to be crawling around their parents' house on oxygen. It's a pretty sad situation, so that's why it's important we take action early. All right, meconium aspiration, or MAS. This is that content of the infant's bowel, usually within the first 2 days after delivery. It is opium-like. That's where they got the term from. It's mostly post-term kids we have this issue with. If you have a kid that's barely term and has it, there's a sign of stress or asphyxia. That can be from that late variables that you would see on their waveforms. And they're just term, they're not late term, then that might be a sign that they might have had asphyxia issues as well. Not definite, but might be a sign. That meconium can pass into the fluid during the stress of delivery as well. So that's something you might see. The big thing that we did here and we'll talk about and we'll play more with in the lab, hopefully, is meconium aspiration. It can cause that ball valve or check valve effect that we talked about before. Where on inhalation, your airways move out, especially on babies because they don't have that cartilage really developed very well. So gas can move past it, and then when the airways collapse for exhalation, then it causes that obstruction, which means it's going to back pressure, and the weakest point can then rupture. So if you see that picture B where you see it all rupturing and all this gas is just flowing out here, it's a very bad thing ultimately. So pneumothorax can easily happen on that term kid with that ball valve or check valve effect there. It can also cause a chemical pneumonitis. Meconium and just poop in general is alkalotic, and your lungs are actually acidotic. The tissue itself has a very low pH. Remember, when you're giving albuterol, the pH is like 3 of albuterol. So when you put a very high base in a very acidic environment, you're going to get a chemical change. It can cause what's called a chemical pneumonitis, and it can even go into this thing called bronchospasm as well, which we would have to give bronchodilators for. Thanks, Aerogen. Right? Aerogen nebulizers. Meconium aspiration signs: they'll have an acidosis, hypoxemia, of course, retractions, grunting, flaring because they can't breathe past the poop. It's in their lungs. They'll sound congested on breath sounds. The x-rays will show just irregular densities. It's not going to be uniformity like ground glass. Treatment, suction of the mouth and nose at delivery. That's just done as part of normal NRP. That's not the whole intubate before that's just normal NRP steps. We actually might give them a higher saturation goal because this can cause pulmonary hypertension. Meconium aspiration can cause pulmonary hypertension, so we might actually give them more oxygen in the meantime, or we might start them on this drug called nitric oxide, inhaled nitric oxide, which is a pulmonary vasodilator. Might help them in the meantime. Gentle ventilation is still needed You don't want to destroy the lung tissue that is getting gas. High frequency ventilation is a big deal here with meconium aspiration syndrome. They're having issues with their saturations and pulmonary hypertension. They might actually switch a kid over to a jet or an oscillator. At PSL, they used to start all meconium aspiration babies on the jet per protocol for the first hour or so after delivery. It's not protocol anymore to do that, but because the way that it would help the gas go past the obstruction and allow for more effective ventilation with less airway destruction, because high frequency is gentle ventilation as long as it's run appropriately. Surfactant, because remember, poop causes a chemical pneumonitis, and that's when it deactivates the surfactant as well. And so that base that deactivated the surfactant, so that means we need to give them productive or effective surfactant, which means we give them surfactant replacement therapy. So this is a term kid that we're giving surfactant replacement therapy to. Antibiotics, of course, for the chemical pneumonitis and or the chance of developing an infection from now this a biological microbe that's in a dark, warm, humid environment. Of course, that can be a breeding ground for microbes, so they might start them on antibiotics as well. And if it's bad enough, they might start them on ECMO. In the NICU, ECMO is usually a last resort. I think in Colorado, there's only 2 places that does ECMO on NICU, and that would be PSL Rocky Mountain Pro Hospital for Children at PSL, and of course Children's Hospital. Complications, of course, pneumothorax would be the big one because that check valve effect, back pressuring, and it's usually in the transition airways that back pressures and ruptures. Intracranial hemorrhage, because the thoracic pressure would increase, therefore back pressures the blood flow to the brain, therefore increases the risk of brain bleed. And of course, premature pulmonary hypertension of the neonate. So that's why we would give that nitric or higher FiO2. Okay, barotrauma and air leak syndromes. These are the 4 ones that we'll talk about pneumothorax. These are 4 P's: pneumothorax, pneumomediastinum, pneumopericardium, and PIE. Pneumothorax is very common with a preterm baby, even if they're not intubated, because the Herringbrew reflex is all they're going off of, and their rib cage won't stop their lungs from hyperinflating because the rib cage is not set yet. So they can get a spont pneuma pretty darn easy, and PIE is something that you usually see in later stages with the RDS management. So let's start with pneumothorax. Most common air leak pneumothorax. Most common air leak pneumothorax. Most common air leak pneumothorax. I think you guys get what I'm trying to say there. 1 to 2% of all newborns in North America, and I think that statistic is still pretty darn accurate. I mean, it's not something we can really prevent because most of them are spont pneumos. This is just mostly spontaneous versus induced. This usually means the kid took too big of a deep breath, back pressured, and causes a rupture, right? Like they're about to cry, poop, like they're about to do something, and they back pressure, and spont pneumo hits. Most of these kids, they may not even have any desaturation. They might just be tachypnic for a little while, and it's less than a 20%, so it resolves its own. Induced would be us doing it, whether we're putting in a line or a vent that has too much pressure on it. And these can lead to a tension. So even if it's spontaneous or induced, then it could still lead to a tension pneumothorax with a vagal and Brady and all that bad stuff. Clinical signs: high respiratory rates, of course, if they develop it. Cyanosis, of course. Chest wall, that'll be looking like a little bit of pendulum. You'll see the asymmetric movement between the chest walls of the right and left side there. Of course, they'll Brady down and they'll stop breathing. Babies tend to shut down, right? They'll Brady and stop breathing. Diagnosis: if you have a transluminator with you, great. If you have a halo, just that little sign like what I was showing you guys the last day we were together, that's normal. If the whole side of the chest lights up, that means there's lots of free air, and it's over 20% pneuma, which means it needs to be treated. So that's usually chest. Usually they'll dart they'll put a needle, they'll needle it and or put a chest tube in, depending on what's faster or how significantly sick the kid is. X-ray, of course, you guys have seen pneumo X-rays. If you see a shift, it usually indicates a tension pneumo. And so here you can see, I'll use red, and here's the outline of the lung. Hopefully you guys can see this. And then you see all this area here is just filled in with nothing, with air that's crushing that lung, which can then cause that mediastinal shift to push that heart over to that left side. This kid has a OG or NG tube there going on, and then a little bit of EKG sticker, but you can of course see that. Treatment, the patient's not intubated and they're stable. In other words, their Silverman-Anderson index is low, then we're just going to observe them, and I will give you a question on the next exam exactly about this situation. If the patient is in severe respiratory distress and their Silverman-Anderson is, let's say, 8, they're retracting, they're nasal flaring, they're working hard to breathe, that's when they'll needle or chest tube this kid. If they're on a ventilator, then they'll put the chest tube to suction, and this is actually a mistype here. It should say 15 to 20 millimeters of mercury. Yeah, I cannot draw with this. You get the picture. So this should say millimeters of mercury. I don't have a pen, so that's the best I can do with my mouse. So 15 to 20 millimeters of mercury. Mediastinum, this is where it goes into the, from the lung, it goes into the interstitium in between the lungs. This actually may impede venous return and cause cardiac tamponade very quickly. If you do see it, their heart sounds are going to be very distant. Like there's something muffling or crushing the heart. It's distant, just like someone that has closed down lungs from asthma. Like you'll just hear almost no air movement because their lungs are so closed down. So treatment, observe for leaks, it should resolve. Their vent pressures will be low because all that pressure is going to their mediastinum. We're just going to watch their hemodynamics. Pneumopericardium, this is where it goes into the pericardial sac. So just like a cardiac tamponade, it tamponades the heart, and their blood pressure will drop fast, and it is a rapid demise. Big thing, though, Brady, their heart sounds will almost be non-existent, and just like you'll need to needle aspirate in the pleural space of the heart. So you'll need to needle aspirate the pericardium to get it out, just like with blood, but only this time with air. PIE is the big thing here. This is the last air leak syndrome. So these are the 4 air leaks. This is the 4th one. So PIE, this is where air will go in through the interstitial tissue of the lungs. It's usually that weakest point in their lungs, which would be the transitional airways, which is what we were talking about earlier. Too much PEEP, too much mean airway pressure, too much PIP, too long of an I time. So too much mean airway pressure, right, is the short way of saying these 3 things. Too much mean airway pressure can cause PIE. So once this happens, the patient requires more vent pressures because they have a more VQ mismatch, which means their PI is going to get worse, and so then they're going to require more pressures, which require more of a VQ mismatch. It's just the vicious cycle. Their x-ray is going to look a lot like these bubbles or cysts, and we'll look at one of those x-rays in a second here. Big treatment here is get them on high frequency. Low pressures, whether it's on the jet or the oscillator. In this situation, I have a preference towards one over the other. If I had to pick, I would obviously pick one over the other. But if you only have an oscillator, then that's all you have. TTN is not an air leak syndrome, so you should know which ones are the air leak syndromes and how they're treated. TTN, this is the most benign of most of these respiratory issues. This is where a kid just retains fetal lung fluid. So respiratory distress, they'll be tachypnic, their x-ray look ground glass, but everything else has been ruled out, then it's TTN. So we ruled out a pneumonia, we ruled out all these other things. Hey, it was just retained fetal lung fluid that caused the x-ray to look why it did and why they were breathing fast for a little while. So it's more risk for preterm babies, C-section babies. So that's one of the big things you look at for C-section babies. You might have to put them on CPAP for, a day or a couple hours or whatever it is, just because of the TTN. Moms that smoked, of course, we know that the lung development's a little off. Moms with diabetes, SGA babies. Treatment, you can give them oxygen, like an oxygen hood, just to help with them a little bit till they reabsorb that fluid. Or give them CPAP more and more, or just go into straight CPAP for the first couple hours at least. PPHN, persistent pulmonary hypertension in the newborn, can cause a right to left shunt through either the FO or the PDA. So it's a big deal. So this decreases ventilation, it increases shunting, which means more likely for metabolic acidosis, and that causes a whole big issue. So hypoxia is one of the biggest causes here. So that pulmonary vasoconstriction, so obviously the fix for hypoxia is oxygen. Great. Meconium aspiration, that could be a cause because it deactivates surfactant, therefore causing low oxygen levels, therefore causing pulmonary vasoconstriction, therefore causing pulmonary hypertension. All right, polycythemia, the red blood cells are too thick, which causes pulmonary hypertension. Sepsis, CDH, all these things can cause PPHN, so we got to look at it. The big thing is these babies will be in respiratory distress, they'll have cyanosis, and you can give them high FiO2s, and it may not make a difference at all. Higher oxygen levels, preductal and postductal, you will see higher levels preductal to the arteriosus is what you'll see. So diagnosis is usually made on echo. They'll look at the gradient on the pre and postductal sites with pulse ox. If the pulse ox is different on the right upper extremity, 5% higher than it is on their left lower extremity, on their left baby foot, then that's a sign of a shunt. So the pre and post difference there is what to look at. If it's greater than 5%, that's definitely a shunting going on. Or they could draw pre and post ABGs, which I've never seen them do, and look at the millimeter of mercury difference between the two. So if the PO2 is different, more than 20, then that's a sign of the shunt as well. But usually it's just the pre and post pulse ox. Treatment, vasodilation as much as you can. Try to give them oxygen, especially if hypoxemia is what's causing the issue. Drugs like sildenafil, high frequency ventilation can easily be a cause or a fix in the meantime, because you're getting better ventilation, better oxygenation, less chance of pulmonary hypertension. Nitric oxide, of course, pulmonary endothelium derived relaxer, or aka pulmonary vasodilator. ECMO if it's severe enough. The big thing here is to maintain their blood pressure. If they get hypotensive, then that'll make their pulmonary hypertension worse because they don't have perfusion to the respiratory zone and they won't pick up the oxygen they need. And that's what we're looking at here, and this is from your book, and what we're looking at is just how much these PDEs, so milrinone, sildenafil, the Viagra, right, they help release and help the endothelial cell relax, and so that way they can vaso-relax or vasodilate, aka, and that will help them get more oxygen into their bloodstream overall. And so one thing here that you see is arachidonic acid up here, and arachidonic acid is one of those things that can easily cause issues with our adults, even at RDS, because they're looking at the COX-1 and COX-1 pathway. And so that's something they've looked at with nutrition helping reduce arachidonic acid, therefore helping it with endothelium cell relaxation.